Hello, and welcome to today's webinar on Lean and Clean, Sphere-9 Catheter Workflow Optimization. I'm Dr. David Wilson, Chief of Electrophysiology at University of South Florida and Medical Director of EP at Tampa General Hospital. It's my pleasure today to be joined by Dr. Nicholas Olson, Cardiac Electrophysiologist at Scripps and from La Jolla, California. Reminder, today's webinar is supported by Medtronic. To start with, let's briefly recap our objectives for today. We're going to discover how the Sphere-9 catheter and Affera mapping and ablation system optimize AFib ablation workflows. And we're going to review a recent case example showing practical workflow tips. So now at this point, I'd like to turn it over to Dr. Nick Olson for his presentation. Following this, we'll have a presentation and discussion exploring the key themes. So please stick around.
Great. Thank you, Dave, for the nice introduction. As Dave mentioned, I'm an electrophysiologist here at Scripps in La Jolla, sunny California, and look forward to taking you through my experience bringing on the Affera Sphere-9 mapping and ablation system, which really has become kind of the workforce ablation system for all our complex atrial arrhythmias now. Just a little bit about my background. Prior to pulse field ablation, like David, I pretty much only use radiofrequency energy point-by-point ablation. I like the versatility, being able to deal with any arrhythmias and non-pulmonary vein substrate that came up during cases. So once Farapulse came on, I did participate in that clinical trial. And obviously, as most who use it, blown away by the efficiency of that system, and also obviously the safety with that system. But with it came new challenges and issues to deal with. So looking forward to next generation, this slide kind of outlines my thoughts after bringing on Farapulse at our system. Certainly I noticed that with pulse field, for whatever reason, a variety of reasons, most likely, our AF ablation volume and referrals rapidly increasing, whether that was due to increased recognizing of AFib through wearables, community outreach, direct-to-consumer advertising, also first-line ablation early referrals. We saw a major uptick in that as well, I think largely from feedback from patients. So moving on from a single-shot Farapulse, these are kind of summarized in my thoughts on where I wanted to see the next system come about. Obviously we want safe and durable lesions with objective therapy feedback, right? I think number one, we enjoyed the safety of lack of collateral damage with pulse field, but certainly safety elements such as hemolysis, renal failure, coronary spasm became new elements to deal with. So addressing those issues. Secondly, I think, for anyone who does a post map on a Farapulse case or pulse field case, after a single lesion and remap, your first inclination is, oh my gosh, I did too much ablation. All the voltage is gone. But clearly, in doing this for a year and bringing patients back, we see that there's a large area of reversible injury. And I think one of the biggest steps that we can take in the future is trying to better identify what areas we've achieved irreversible injury and which ones are reversibly injured. Secondly, with these new systems, we want to maintain and improve our efficient procedural workflows. And obviously, we want to continue with our clinical outcomes, make them consistent and hopefully improved with advent of that technology. So this was Sphere-9 and Affera's answer to that call, the Sphere-9 catheter and ablation system. As you can see, this is a 9mm sphere catheter, providing both radiofrequency, the mini electrodes on the surface, also coupled with thermocouplers at those sites. And these thermocouplers are right on the surface, which really give you a great ascertainment of what the tissue temperature is doing. And that has allowed a transition back to temperature-controlled RF ablation. And I think that has really provided quite a powerful radiofrequency tool. I mean, this was initially designed as an RF catheter, and later pulse field energy also included with its toggling between the two. But electrograms are close unipolar EGMs created from each one of these electrodes to a central terminal, so not quite bipolar mapping. One of the hesitations or concerns that I initially had with the system was, are we going back to point-by-point mapping? Is this catheter going to be too small to create three-dimensional maps in a timely fashion? And certainly I had some hesitations with that, especially after using high density catheters like Grid and Penere. But to my surprise, this system, I really think the 9 mm sphere is really an optimal size for both mapping and ablation, big enough to create a nice map quickly, but the ablation profile and size of the ablation lesions is small enough where I feel like I still have I'm able to paint the atrium with more of a fine point than these large swaths with the single shock catheters. So that's what I was most excited about when I brought this system online at Scripps. So a little bit about the cage design. I think from a safety perspective, it really absorbs tissue contact quite well. And with that lattice design, really holds the tissue very firm, therefore creating very nice, consistent lesions, both for radiofrequency energy and pulse field ablation energy. As you can see here, both with lateral motion and direct tip pressure, how the tissue tip deforms quite readily and holds position to give a thorough lesion at these sites. The profile much larger than a focal tip catheter as well, and as a result, larger lesions we're seeing both with PF and RF. Average lesion widths around 18 to 17 millimeters with depths at about 5 to 5.5 millimeters. As you can see, the size of the lesions very similar between RF and PF. I think that can be a little bit of a misnomer. Some initial thoughts were that PF was going to create consistently larger lesions. That hasn't been true with the Affera system, but certainly both of these lesions are quite a bit wider, double the size of our standard point-by-point solid tip catheters. Just a little quick comment about safety. I think moving into the arena of pulse field ablation, I was happy to see, our safety profile improve dramatically with the lack of collateral damage, such as the esophagus, vagal nerve, phrenic nerve, and also really what I really like about pulse field is once we start moving out of the pulmonary veins and start attacking larger tissue areas, the lack of stiffening of the left atrium is something that I think is underplayed with RF, which I really had a problem with in these advanced AFib patients. And really, we're not seeing a lot of that stiffening either acutely or long-term in terms of diastolic heart failure, diuretic resistance. And I think that that's going to be prove to be a real useful aspect of this technology. Secondly, hemolysis, but with PF, new safety features and concerns come about, coronary spasm. Obviously, that can be addressed by toggling between RF and PF with this catheter. And I think that's really helpful as opposed to switching catheters with other systems. A quick comment about hemolysis, although it is a class effect with pulse field ablation. This nice abstract this year really demonstrated there seems to be quite a bit less hemolysis with the Affera system. This nice study compared hemolysis between the Affera pulse system and the Affera Sphere-9 catheter. Hemolysis grading on the scale there on the left, moderate 50 and below milligrams per deciliter of free hemoglobin, severe 100 and above, as you can see in the bottom right. Usually with 40 to 80 lesions on the Farapulse catheter, which is a common, I think that's a common number of applications for standard cases. You can see that there's quite a splay of degrees of hemolysis. And although there is a correlation between number of lesions and the degree of hemolysis, it's not a tight linear, line. There are some significant variations, and even with standard lesions less than 75 applications, you can see quite severe hemolysis. notably with a Sphere-9 and similar degrees of ablation. These are typically in the 90 to 100 lesion applications. We see a moderate to severe hemolysis with Farapulse was 62 and 25%. However, with Sphere-9, there was no cases of moderate or severe hemolysis. So I think although there's a class effect of hemolysis with PF, Sphere-9 seems to induce it quite less readily. And I think that that's an important aspect. So with pulse field ablation, I think in general, the time between our ablation or ablating becomes more of a factor than the time during the ablation. So in terms of procedural efficiency workflow, I just wanted to make a quick comment about the time in between ablations. That's access, transseptal closure, and turnover. And this is kind of how I've learned to approach this. So when we bring a patient in the lab, we do 3 femoral vein accesses. We do a 10 French, 7 French, and either an SOL or a Jolla 8.5 for the Affera catheter. It's a return to a smaller catheter, which is much improved in the terms of maneuverability. I really like that aspect to it, being able to move the catheter around quite briskly as opposed to these larger sheaths. Secondly, closure becomes less onerous with the smaller sheath and resulting in a shorter bed rest period and more and a quicker hemostasis profile. Once we go with access, we go directly to left atrial access, either with a Baylis or a VersaCross RF wire. If we're using the Agilis, we actually make access with the VersaCross wire and then simply pull it back to go directly into the left atrium. I like to do the left atrial ablation. As we're completing the left atrial ablation, I do the CTI line if we're going to do that at the end of the case. And the reason for that is that we do use and recommend paralytics during these cases because even though there is a smaller profile for this catheter, there still seems to be quite a bit of phrenic nerve stimulation during left atrial ablation. So at the end of the case, when we're approaching completion of our left atrial ablation, I'll communicate with my anesthesiologist and say, hey, we're moving back to the right atrium. We give paralytic reversal. We start the anesthesia wean. We pull back and do the CTI with radio frequency energy for the most part to avoid coronary injury. And usually, and the one thing that I'd like to note about the CTI ablation with this system is by using this large focal efficient RF catheter as well as pulse field ablation in the nooks and crannies and crevasses of a CTI, the CTI ablation time is very consistent and usually only 3 or 4 minutes. Therefore, timing with anesthesia wean seems to be very predictable. Then we proceed with 3 PERT closes at the end of the case, 1 hour of bed rest, ambulation, and DC. And this provides a very nice throughput through our EP lab and an efficient workflow. So let me take you through 2 quick cases here. The first, I want to show you just kind of one option is I call this the full build out map where we create full 3-dimensional anatomy. And this particular patient had a history of AFib and flutter, 67-year-old, symptomatic, wants to be off anticoagulation, so came to clinic to discuss ablation, potential left atrial appendage closure. Ultimately, we actually enrolled this patient in a targeted anticoagulation trial as it didn't qualify for Watchman, or left atrial appendage closure. But regardless, we took the patient and did a simple PVI procedure. However, as we let me take you through this. In this particular case, I wanted to demonstrate kind of a full build out. As you can see there, the catheter manipulating around the left atrium, the little white dot on the catheter tip represents a localized impedance based off of the surface electrode and that central terminal and can be used to assess tissue proximity. I like utilizing that in areas where we haven't seen much voltage and determining whether that's scar or poor contact, we can use that localized impedance to say, hey, I've made close to tissue proximity in that location. So that's a nice feature for the mapping part of utilizing this system. It can also be, obviously, we want to see that localized impedance change before we deliver our application of energy, whether that's pulse field or radio frequency energy. As you can see with the 9mm globe, we're quickly acquiring the anatomy. And overall, our map completion times, I would say, are not significantly longer than using any high density catheter such as a pen array or a grid type catheter. I think that largely stems from the rapid automated acquisition and the ease of maneuverability of this catheter really behaves like an RF catheter does. And with that, it's really easy to access pretty much all areas of the right and left atrium, which can obviously be challenging with a larger catheter, especially a Affera nav catheter, or even with larger grid or Penarate catheters. I think this catheter even does a better job of accessing all those areas quite quickly. So as you can see here, we're finishing up mapping of this case. And one feature that ultimately I didn't show in this particular video is there's a nice feature where we can put the catheter in the left-sided veins, and we call it vein mode, and that will acquire some data in that left vein and really quickly outline the ridge. Here we go. That converts over to vein mode and will actually acquire some points. And then the system will eloquently disconnect the left atrial appendage from the left superior pulmonary vein without any editing. And this, as we pull around, we'll really see that that Coumadin ridge outlined very nicely there without any editing there. You can see the nice ridge that was outlined, and that obviously helps for ablation along that ligament of Marshall Coumadin ridge area. So this is a full, obviously the full anatomy achieved. Then we deliver our lesions. I'll show you a little bit more about the lesion delivery in the next example, but we did a simple pulmonary vein isolation there. As you can see on the left, very efficient workflow, CTI completed, and I'll show that at the end of the slide presentation as well. So a second case, and I call this the build as you go, and I think that's, I really believe personally that mapping and ablating with the same catheter is really the future of these complex atrial arrhythmias. I like the ability to map and ablate with a single catheter, with safety and efficiency at mind. So in this particular example here, here we go, I got the video to play. So in this particular example of this 63-year-old patient with persistent AFib, we put the catheter in, we got the left-sided veins, and they're in AFib. So I said, let's build the veins and isolate them as we're going. And then if we get some organization to flutter, then we can map the rest of the chamber quite briskly using when they're in the flutter. So we got some basic anatomy of the left-sided pulmonary veins. As you can see, when we come on with PF, this is leaving you can see there is to assess whether you are actually delivering an effective lesion. We look there at the top, that blue globe at the top. Even with pulse field energy, there is a small temperature increase with application of pulse field energy. And that 2-degree temperature change is detected by the system. And with that, and that is our objective feedback that we're effectively delivering a lesion. And I think that's a unique feature of the system, and that we're not just predicting lesions based off of a projected voltage density on a map that we created. We're actually getting tissue feedback from the catheter to say, hey, this is an effective lesion in this location. So with the system, if we get that 2-degree temperature increase with pulse field, we'll get a green lesion. And if it doesn't achieve that, we'll get a blue lesion, and we know we have to re-ablate that location. There is also, we'll track the distance between our lesions, and I'll show that in an upcoming slide to make sure we get effective overlap of 5 to 6 millimeters between our lesions as well. But as you can see, as we were going through this, we're making these lesions as we go and creating some anatomy. Now we're over on the right side. And as you can see, we already isolated the left-sided pulmonary veins. We're making the anatomy of the right-sided pulmonary veins. There's some blue cords in between our lesions there on the right side, and I just wanted to highlight that really outlines quite eloquently where we haven't made sufficient overlap of our ablation lesions, whether they're RF or PF. And we can go back and localize those spots and make sure we have deliver effective therapy in those zones. Okay, here we go, getting the video playing. As you can see there, we're going to move the catheter around as we deliver some energy. On the top, we see our temperature. We get a nice temperature increase, and that cord goes away, that blue cord. And then we can move on to the rest of our pulmonary vein isolation. In this particular example, as we were completing the right-sided pulmonary vein isolation, the arrhythmia organized or slowed and terminated and was non-inducible with simple wide circumferential pulmonary vein isolation. Therefore, we did not move on to additional ablation in this patient. if they, obviously, if they remain in atrial fibrillation, often, and my personal workflow is that we'll map out and try to target some additional non-pulmonary vein substrates just to see if we can get some response, some cycle length slowing, or even termination as well. Once we pull back to the right side, we can see red lesions are for our radio frequency energy. To get an effective red lesion, you need to obviously make a temperature. There is a temperature threshold that needs to be achieved. Again, this is a temperature controlled system, so it will ramp watts and current until effective tissue temperature is seen. And I think that's one of the really powerful tools of this system, is it has the confidence of knowing what the tissue temperature is, and therefore can deliver much higher wattage and current than would otherwise be with simple power controlled RF ablation. After completion of the CTI line, the globe has a nice feature, which is a propagation arrow. So when we pace on our coronary sinus, we can see quite quickly that our CTI is blocked by the propagation arrow pointing towards our line, as opposed to having to manually create a whole other map. And I think this is another nice feature of a very complicated or a multi-electrode catheter, is to demonstrate in the user interface. Demonstrating propagation is a very nice feature for efficiency. Intracardiac ultrasound. This is a very echogenic catheter, and I think that's very helpful if you're an ICE user for your ablations and want to localize the catheter and assess its lesion formation during application of PF or RF. This catheter is very nice to monitor and view with any ICE system as well. So that kind of concludes a little summary of my experience. I think overall, my takeaway from bringing on the system is that this is a big step in the right direction with mapping and ablation system. I'll give it to Medtronic for a first generation mapping system. I've used a lot of first generation systems in the R&D world, and they almost always have bugs and issues that need to be ironed out. This was clearly designed with electrophysiologist input on what is useful. And I think, overall, I've just been really blown away by the system, not just the ablation technology, but the mapping system as well on the user interface. I think it's a really excellent tool. And again, it has really become the workhorse of our complex atrial arrhythmias here at Scripps.
Excellent. Nick, thank you for those two great cases. One of them showing us standard workflow, generating a detailed multipolar map prior to ablation, and one with an expedited workflow. First thought that I have is, do you find that with your expedited workflow that you tend to lean on ICE imaging more than you do with your standard approach, pre-mapping approach?
So, great question. The answer to that is no. I think with this system, there's a lot of feedback mechanisms on the user interface that you don't have to do that. I think I have minimal concern about pushing too hard and perforating with the catheter because of the design of that lattice being such a shock absorber for any type of tissue contact. Secondly, we have the localized impedance changes that you can see on the user interface as you're moving the catheter around to say, hey, I'm touching tissue in this location. And also with that design, there does seem to be some real tactile feedback through the catheter when you're manipulating it to really get an ascertainment of, yes, I'm touching tissue in this location. And lastly, when you deliver energy, we have some objective feedback criteria with this temperature feedback mechanism, whether you're using RF or PF, to say, hey, I'm delivering energy into the tissue and getting some feedback from the tissue. So typically, I don't use a lot of ICE anymore. I mean, if there's something if it's behaving in a way that I just feel like it doesn't make sense to me, yeah, I'll turn the ICE over there and try to see what's going on. But for the most part, I don't think a lot of ICE use is even needed.
Yeah, I second that. I'll say the only area that I reliably use ice is just at the ridge, just to make sure that my contact is true there and determine my depth on the ridge. I personally have leaned less on vein mode and generating my pre-map with Affera. And for that reason, I just find that simple ice imaging just when I'm along the ridge for the 3 or 4 lesions that are needed is quite adequate to give me the confidence and reliability in that area. Well, we have some audience questions now. First one, Nick, in persistent AFib, do you prefer mapping before ablation or do you go directly with your Sphere-9? Now, I'm presuming that this question is geared towards whether we map in AFib and whether it's more of an anatomic or voltage guided approach. What's your take on that?
So I like to do, so what I usually do in that setting is if they're in AFib when they come in, I'll go to the veins and I'll do the pulmonary vein isolation. I know I'm going to do it anyways. And if they're in AFib already and I do the pulmonary veins and they organize into an atrial flutter, then I have something that I think is a little bit more, I mean, things change after you do the pulmonary vein isolation. So I think it's nice to be able to do the PVI first, see what happens, and then map based on what happened during pulmonary vein isolation. If it's a flutter, we map the flutter. If they remain in AFib, then we'll evaluate the substrate. And Dave, after I finish my comment here, I'd like you to maybe make a comment on what you think about the meaning of these close unipolar electrograms, and do they mean do they mean the same thing as bipolar electrograms? Can we use them in the same way to assess complex fractionation? What are some concerns of using localized or I should say close unipolar electrograms versus true bipolar electrograms? But just to finish that comment or the answer to that question, I like to, after finishing the pulmonary vein isolation, if they terminate during a PVI, great, that feels great. But if not, I will oftentimes go investigate the rest of the atrium and make the rest of my 3-dimensional map at that time.
Yeah, and I would add to that. I think this comes down to for an index AFib ablation procedure, are you a PVI operator or PVI plus? And if you're PVI plus, are you PVI plus targeted anatomic isolation like posterior wall CTI, or are you PVI plus substrate modification? I would second what you said, Nick. I think I do not have the experience or confidence looking at those unipolar EGMs to do a refined substrate modification using voltage in AFib. So in that regard, I do map in AFib. I care less about the relevant voltage going into every individual case based on the patient's individual needs. I generally have a PVI or PVI plus strategy that is more anatomic based. And for that reason, I think Sphere-9 certainly is the best of both worlds. I mean, going back to what you said before, understanding that as all of these first gen PFA catheters come out, we're going to have both single shot, point by point, and this intermediate size footprint. I think this intermediate size footprint really is going to be the Goldilocks porridge, and everything's going to be just right. Having the option of dual energy with both RF and PFA, as well as that intermediate size footprint, does really offer the best of both worlds. That added flexibility of more consistent with the single shot, but the expedited workflows that we see with our single. The flexibility of a point by point, but the expedited workflow of a single shot. So other questions. Can we use this catheter to reliably achieve bidirectional block for atypical flutters? What's your experience with that, Nick?
So yeah, I mean, I think David and I were chatting before we came on this webinar, and I think one thing that we were both taken aback by was the reliability of achieving block on linear ablation lesion sets that prior to Affera and Sphere-9 were challenging, if not impossible to achieve in all patients. For example, left lateral or a mitral isthmus line. I have yet to see, I've probably done almost 200 cases now, obviously not all doing mitral isthmus, but I've yet to see a mitral isthmus line not block on a first pass. I mean, that is unheard of with RF and even with Farapulse. I think Farapulse, again, I don't have experience with other PFA systems, but achieving mitral isthmus block is very challenging, and the durability of that mitral isthmus block is even more challenging. So I think, yes, this catheter can definitely achieve a bidirectional block. The durability of that, I think that's always going to be statistically hard to, without remapping studies, is going to be a hard answer. I can say that I'm not seeing anecdotally a lot of these mitral isthmus block patients coming back with recurrent mitral isthmus flutters. In fact, I haven't seen that happen yet. The ability to deliver radio frequency energy and PF energy right on top of it. We were talking a little bit about that, David and I were, before we got on this call as well, delivering an RF lesion, although, I certainly think there's some science to say, hey, preconditioning with RF followed by PF can potentially increase your lesion size. Whether that translates, with this system in vivo, I think that's always a question mark, but I like the concept of that. As David said as well, the science makes sense. But you have the ability to do that on a mitral isthmus line, doing RF and then PF. And secondly, I think assessing the block is, with one catheter in the left atrium, that's always going to be a little bit of a challenge because you can't pace and record right next to the line on both sides. But for the most part, with the propagation arrow and the coronary sinus catheter, especially if you're going with a lateral mitral isthmus line, I think you can assess that bidirectional block quite readily.
I agree with everything you said, Nick. It's certainly changed a patient converting into a mitral flutter where you might honestly start thinking about delaying your next case and wondering what adventures you're going to have to head down to get block, to now a fairly reliable several minute procedure, but one that does not give you any anxiety at all. I'm probably 10 to 15 mitral lines in terms of de novo flutters, doing occasionally both anterior or posterior lines, depending on the patient's individual substrate at that point. And I've yet to achieve bidirectional block on first pass and flutter termination. So, all right, maybe probably have time for one more question, looking at the time. Any special integration or changes in workflows in your relationship with anesthesia for Affera cases?
I think I wouldn't say changes, but I think that slide that I pointed out before I showed the case presentations, I think that's a very important conversation to have with your lab. The case times, I think efficiency was an important outcome of transition to PFA and especially with Affera. But more so than that, consistency. Case times are very consistent. You don't have these 45-minute case, 45-minute case, 3-hour case, and you can't predict what that 3-hour case is going to be. That's always the roadblock in your day, right? Something that you didn't expect. And I think that can be a challenge with throughput in the EP lab, dealing with patient flow, dealing with anesthesia, just the unpredictable nature of that. But I think this is a very predictable. Your stages of the ablation and your time before and after is very predictable. So I like to have a conversation with the anesthesiologist. Hey, and once I work with the same ones over and over again, they get that. But I like to remind them, hey, this is my ETA to completion. So you don't finish your CTI and they're like, what? You're done? And then they start their anesthesia wean, and 30 minutes later, the patient's finally getting extubated. I think being that communication, and I love it when I pull right back and they pull the tube right out of the patient. I mean, that's the perfect efficient day if we can just get that type of workflow going. And I think that's a real possibility. But also, I mean, talking, creating a system in your pre and your post-op area to deal with these increased number of patients and how quickly the turnover was. I think that was an unforeseen issue in our lab was, patients go in and then all of a sudden 30 minutes later, they're 45 minutes later, they're coming back out again. That was a real roadblock. And we had to, create more staff and more space to deal with that. I think using, uh, using closure devices on the groin, very helpful in that throughput, patient satisfaction. I think if you look at, there's a lot of data to say from a cost perspective that it actually reduces cost by decreased resource utilization. And that's why I've been able to continue to use closure devices on all these vein accesses, because if you look at the statistics and the math behind it, it actually pencils out. So I think those are some elements I just wanted to touch on.
Yeah, and I agree. The one thing I'll add is I think that predictability and procedure time has not only helped communication with anesthesia and our wake-up times, it's also helped our staff. They're a little more on point where they know exactly from the time that we're completed with our steps for transseptal to when I'll likely be finished in needing closure devices. So I think it's kept everyone a little more alert and attentive to procedure times and processes because they are so predictable. One last thing, and we'll try to move to a high efficiency answering here of questions, but we'll say I'll try and take two at one time. Do you drive the catheter with sheath or without it? And the second that I'll try and integrate with that is how predictable the workflow is for operators with varying levels of experience. And I'll take that, and then Nick, I'd like you to give your take. But my opinion is that if you are an experienced RF operator, just do whatever you're doing with RF. It will be amazing to you when you first get this catheter in your hand, how similar it's going to feel to an RF catheter. So me personally, I use an Agilis, and I am predominantly sheath driven. And I think that has served me fine with this. And in terms of predictability based on levels of experience, I think there is a very, very shallow learning curve with this. If you are at all experienced using a point-by-point catheter, but don't have any experience with the system, you're going to find that within a case or two, you're going to have map generation times that are on par with the high-density mapping catheters from competitive systems. So I would not worry about that. Nick, any further comments?
No, I think I would just echo exactly what you said. And that is, you can do either sheath driven or catheter driven, whatever your preference was with a radio frequency single point catheter. It feels and manipulates exactly like a point by point catheter does.
Yeah.
And quite frankly, it's easier
Nick,
to use.
Yeah.
Last comment. Going back to a small 8.5 French sheath, it's such a breath of fresh air for me to go back to that smaller maneuverable sheath than dealing with this big clunky thing with a potential valve that leaks air, not having to pull the catheter back in and out. I think that's a real selling point of the system.
Great way to end it, Nick. So I'd like to thank everyone for joining us tonight. I'd like to thank Dr. Olson for his wonderful insights and two very interesting cases. I'd like to remind you that today's presentation was supported by Medtronic. All right. Thank you, everyone. Good night.